look at, again, a not so great coronal view. It looks like the nasal bone sort of piriform aperture is intact, but and not really anything clear going on with bone here. But the concern was that with sort of this broad abutting of the bone, that truly clearing this was gonna take a little more than probably most surgery would do for us. So here he is on the table, and we draw this out as a prediction and then resect to negative margins. And it ends up that when we take out the skin, sort of down to the nasal bone and maxilla, that there's deep tumor clearly involving the face of the maxilla and extending up into the bone of the inferior orbital rim. And so we essentially perform an anterior maxillectomy and remove the lacrimal sac, part of the inferior orbital rim and floor. And he looks like this. Not sure why we didn't pull the pledgets out to take the picture, but everything's clear in retrospect. As my mother says, hindsight is 50-50. So some of you will get that later. But this is an opening into the maxillary sinus, but interestingly, no opening into the nasal cavity. There is, some of the orbital fat kind of pooching out here. And so this question is for, this one's too tough for me, Sam. So this question is for you. How would you, this was a bit before you arrived. So how would you, what would your immediate take on this be?
Well, thank you for not saving him for me to arrive, because this is definitely one when you're looking at the reconstructive ladder. You have to look at the top of the ladder and consider free tissue transfer as well whenever you have this depth of a defect involving the maxillary sinus. So I would be also asking Dr. Garneau for his input. I think there are, if you look at just local regional type of reconstructive options, you could reconstruct. Big issue is biggest challenge here, because if you just brought a skin flap over top of this, say a cheek advancement flap, it's going to be very, very deficient. May provide a little better color match than a free tissue transfer, but your volume is going to be off, and it's going to then contract the nose, even though there's not intranasal involvement, you're going to get nasal obstruction, most likely a nasal valve collapse. So if you say this patient is absolutely not a free tissue transfer candidate for whatever reason, you could try to advance some of the deeper cheek, kind of that SMAS midfacial fat pad tissue up and pexiate to the remaining inferior orbital rim, so that you kind of exclude the maxillary sinus and get that covered with vascularized tissue. And then separately, you can advance that separate to the overlying skin coverage with a large or cervicofacial type advancement flap. And then, to think about the subunit distinction, you could also reconstruct the nose subunit, the sidewall, with the different flaps, such as a forehead flap. In an aggressive cancer like this, you always think about, am I burning my reconstruction for potentially down the road? But I think this is one where I would have a second opinion with a microvascular surgeon as well, just to consider that option.
All right, so John, if we can maybe, let's two questions. If you were going to do this with free tissue, what would you use? And the second question is, would you routinely do something with that orbital floor rim defect or not?
That's a good question. So, I mean, immediately,
I would throw into this man is not terribly concerned about his appearance. I know we've talked about, meeting the patient's expectations. He admitted to having really pretty low expectations for all of this. Not that we should, our goal is still the same, but I'll throw that out there for your consideration.
Sure. So if we, let's say the soft tissue defect on the cheek was a little bit more, I would say the biggest consideration of doing a free flap, ideally what comes to mind and kind of matching that thickness and pliability, probably prefer a radial forearm because it's nice and thin. The color match will be an issue, and also, as Dr. Oyer alluded to, separating the subunits. So you wouldn't necessarily want to just put the entire flap and have it be this undulating piece of tissue that crosses multiple subunits. You would try to at least isolate the lateral nasal wall or the dorsum and a little bit, of the upper lip subunit to then have your flap only be incorporated there. So at least the color mismatch is respected to one of the facial subunits. As a point with the underlying bone, let's say you were to pick a radial forearm and we're going to do it anyways, this would be a nice indication for osteocutaneous forearm. Weirdly selective case, right? Because you have small amount of bone. You're not trying to get extreme amount of bone stock. You could shape part of the radius into the inferior orbital floor and actually have it drape or even span a little bit of that maxilla defect, at least just as a scaffold. You're not going to get enough bone to probably span the whole defect, but at least it's a construct to hold your flap. You could take part of the radius and use that. Let's say you didn't want to use radius bone, or you could get away with cervical facial advancements or big local reconstruction. I've seen before in residency actually taking part of the inferior mandibular rim and actually using that as an orbital rim, because it actually, you can take a little boat-shaped wedge out of the inferior mandible and actually use that. So sort of like a free bone graft option, or even if you were going to do something on the scalp or the head, you could technically do like a split thickness calvario bone graft. Even get fancy and do a temporalis, pedicled flap with underlying bone and fascia. But I think if you're going the free flap route, radioform would be nice, and then you could take underlying bone with that, and that would make it work.
Okay, great. The decision at the time was, pretty limited bone defect. Most of the sinus mucosa still present. This is kind of there's a lot of soft tissue sitting here still. So this through and through defect is pretty small. And so, I actually, Dr. Christfeld did this, an orbital floor reconstruction with temporalis fascia, and of course the medial canthal resuspension. And then he did essentially a V to Y flap with the cheek and a bilobe flap from the dorsal nose, and ended up with this, which, I think one of the advantages, I think, with the local tissue, as Dr. Oyer pointed out, is that this, there's in this individual, that cheek tissue is pretty thick and gives you pretty good fill in on top of that maxillary defect. And here's how he looked at 3 weeks. We have actually struggled to get him back for subsequent follow-up. That's been a bit of a challenge. And the next question I have here, so surgical pathology shows us a 2.5 centimeter tumor with bone involvement, negative margins. Chris, adjuvant radiation for this patient?
Well, if he shows back up, I would hope for him to come in and talk about it. With the bone involvement, I think that there's a benefit. For whatever reason, with basal cell, the only consensus I said where people agree that patients absolutely need adjuvant radiation is with PNI, which, if you look at some of the data, it doesn't totally make sense, because it's someone who has, true bone invasion, absolutely, I think they need it. The issue here for us is going to be, depending on how far we have to get into the orbit, you could have a lot of toxicity related to that, but it kind of is what it is. So, you might have some dry eye and a lot of irritation that may never really resolve, on top of, issues you'd have following the surgery.
Okay, great. Well, thanks everyone for your input. We're going to go to case 3, second case, aptly numbered. And so this is an 88-year-old male who's sent for squamous cell carcinoma of 3 places: the right forehead, the left cheek, and the left tragus. So he has a history of multiple skin cancers. He's had a melanoma of the right neck that was excised years prior and underwent a rotational flap to close that defect. Has been observed since. Then a Mohs excision of this original left ear lesion 4 years prior, and which was notable for perineural invasion, and he got 50 gray of radiation postoperatively in 20 fractions, not here but elsewhere. So he has some other medical problems, most notably AFib on Eliquis, but a reasonably healthy 88-year-old male. And these are his 3 lesions, none of them particularly impressive. But this one, the dermatologist was concerned that it looked a little bit more diffuse and infiltrative. This one, you can see the prior resection, but again, a fairly small lesion. I think in that site, a lot of the bulk of the lesion had actually been removed with the shave biopsy. We review the pathology and they all come back sort of as expected: invasive squamous cell carcinoma. The tragus is a little more on the poorly differentiated side, the forehead more on the well differentiated side, but nothing too shocking there, and no perineural invasion noted in any of these, except that this tragus lesion is thought to be a recurrence of the prior lesion that did have perineural invasion and was previously radiated postoperatively. John, workup that you would do for this patient? Anything more you would do to tee him up, or would you just go ahead and operate on these spots? Thoughts on that?
I'm always a little wary of prior treatment, and I think multiple sites that, I was just saying to Dr. Oria, that look pretty subtle. The actual lesion itself looks subtle, and if something just kind of doesn't really add up, as everyone knows, I have a low threshold to image in general, but I would probably work this up a little bit more before diving in and taking care of all those things, especially with the radiation history. So starting with some preoperative imaging, even just a basic CT neck.
Mark, would you jump in and do Mohs on these? Would you get a scan? How would you play this?
I think in this situation, I would get a scan and look to see, because that's a lot of skin cancer, and he's had skin cancer in these areas before. Did the left tragus have any indication histologically that it could be a metastatic lesion versus a primary? Or was that clear?
On this initial or in the prior? On this biopsy, it was thought to be involving the skin, so not a metastatic lesion.
Yeah, I think before I did jump in, because of the number that he's getting, and again, the biopsies will show 1 degree of differentiation, but oftentimes intraoperatively it shows something more. So I think this is a good case where before you jump in surgically, you get some imaging to get a better idea of the landscape.
All right. Well, this wouldn't be a terribly interesting case if I didn't add on a couple of little factoids for you. He also has a left facial paralysis, which per the patient occurred about 1.5 years ago and was diagnosed as Bell's palsy. Nice follow on to your comments yesterday. And oh, by the way, he also has left mid-facial numbness, which he complains of, but is also confirmed on exam. So I think we'd probably, in that setting, all be in the imaging camp. And
yeah, I don't want to lock in my answer. I may change my answer to an MRI.
Okay, yeah. That's right. Yeah. So MRI, because
more worried about perineural invasion at this point, and likely. What's interesting, and I don't know, kind of fun. We're all used to looking at CTs a lot more. And I think it's even funny when you look at certain literature, what the ideal imaging is. A lot of time it kind of hedges between both. And I think in this case, actually a combination of both CT and an MRI would, at least in my opinion, would not be wrong, and would probably give you the most information about underlying bone, prior treatment effects, and then also the perineural spread too, because honestly, the way MRIs are done and the way I kind of interpret them for surgical planning, it's a little bit harder to kind of get a roadmap for what you're eventually going to do. So I would probably add the MRI to a CT in reality. But.
All right. So his MRI, sorry, it's a little bit long, but it is kind of interesting, shows abnormal thickening and contrast enhancement in left V2, extending into Meckel's cave, the foramen rotundum, the PPF, and suggesting peritumoral spread. Interestingly, only a mildly asymmetric thickening of the extracranial left facial nerve, and not really enhancing, and it sort of wasn't clear what was going on there. And then nothing in the sort of connections between 5 and 7 that might explain, tumor spread in both of those sites, or tumor spread really. The thinking is it spreading from the prior tragus parotid area where there was perineural invasion and crossing over to the 5th cranial nerve. But interestingly, asymmetric volume loss of the left masseter as well, kind of suggesting that there may be some involvement of V3 or more proximal involvement of the trigeminal nerve. I will help all of us with with some arrows, because these are tough to see. And so this is the proximal V2 involvement, and you can see here in the area of the cavernous sinus, compared to the other side, significant thickening and enhancement. This is actually the thickening of the extracranial facial nerve here, which is compared to the other side larger, but not particularly enhancing. And then if you compare this sort of volume of this masseter to the other side, there's notable volume loss there as well. And so I think the question is, now what? And so based on these images, it might suggest what we did next. We just said we're going to take him to the operating room and take these things out. The peritumoral spread is something obviously we can't address surgically, but we will get to that. We still really need to deal with these 3 primary lesions that we have. And so I always, Darren, if you drew a first pass on these lesions, would this be what you would draw, or would it be smaller?
I think in this situation, with this being a poorly differentiated squame on the tragus, I would have gone wider than that. I think on the medial cheek there and the forehead, I think I would have kept those margins to some degree. Something I kind of tell our residents about: if you have a poorly differentiated squamous cell carcinoma and you get that on a superficial biopsy, it's not going to make keratin. It's not going to look like anything in the skin other than pink skin. This guy's pink everywhere. So this is anybody's guess where this thing is going to stop, and they can go, forever. So I would start wide there again, but we're doing this with the patient awake. I'm taking some of his time with each time we're going back. It's an aggressive cancer. We're going from tissue preservation mode to life preservation mode. And so I would open that up a little bit.
Yeah, sure. So we started with that one and attempted to clear our margins, anticipating that we probably, we might have to do a second pass. And, as we got into that, there was actually a little more, tumor deep to this, involving the tragal cartilage. What I didn't say is there actually was a CT on this patient, which interestingly showed almost nothing at all 3 sites. The soft tissue effects of these tumors was actually interestingly very unrevealing. But you can see how there's even a little bit more scabbing here than there was a few weeks prior when we saw him in the office. This was a case that I called Dr. Oyer about, actually mostly because I thought this was an opportunity to potentially help him with his facial paralysis. He was also complaining of a little bit of drooling on the left side. And I thought, since we had him asleep, it was an opportunity. So Sam, why don't you tell us about what your thinking was on how to manage this guy?
Well, yeah, and thank you for, I saw him pre-op as well, so I was able to get a sense of what his wishes are, and that's always preferable rather than, hey, he's on the table, what can you do? So I appreciate you kind of getting me involved with that. And this guy was on the side of, I want almost nothing done. I want as little as humanly possible. And he's not a candidate for masseter nerve transfer. He's barely a candidate for any kind of actual dynamic reinnervation, because he's had 1.5 years of, of course, Bell's palsy. So his main symptoms were drooling and ptotic lower face. So through that cheek incision, through the skin cancer resection, just the act of closing that provides a little bit of lift. And I augmented that with just a little, how I love fascia lata, just a little direct sling suture to the upper lip and commissure, and just working through that incision kind of tunneled that back to the infraorbital rim and PEC-C'd it in that location. So a very minimalist approach to try to give him improvement in the one symptom he was most complaining about.
Yeah, thanks, Sam. We unfortunately, between Sam and I, neither one of us got pictures either intraoperatively or actually postoperatively. So I said we're going to all use our imagination. But I thought when I saw him post-op that he had a fantastic result and actually noted some improvement in the oral symptoms. We actually put a split thickness skin graft on the tragal defect. And with those, you know, we have lots of soft tissue there. So this was abutting some of the parotid tissue. We put some wicks in the ear canal and a bolster on that. And so he has sort of a bowl defect there with the skin graft. But again, as Dr. Oyer said, just trying to keep it as simplistic as possible for this man. Here's what we ended up with from our pathologist. The right forehead lesion was just scar. The left cheek lesion had no perineural invasion, but was still a moderately differentiated squame, depth of invasion 1.8 millimeters. And then the left tragus lesion was a deeper lesion, more poorly differentiated with substantial perineural invasion noted in nerves, at least at that 0.1 millimeter mark. So I think the challenge is adjuvant therapy. Chris, we would obviously think of radiotherapy, except we're back into that issue of already having had treatment, but now having this, perineural spread into all the way to his cavernous sinus. So what's your thinking on that?
Yeah, well, this is my favorite situation where somebody really needs radiation and they had radiation exactly to the same place. In situations like this, it's extremely helpful to know exactly what they did before. So if it was a small field, just a little part of the ear and a lot of that tissue's been resected, we could probably get away with doing something, but it's impossible to know otherwise. But he really does need radiation, and not just to the the superficial tissues, but we would need to track the trigeminal nerve all the way back into the trigeminal ganglion in Meckel's cave. And it looks like it's enhancing in Meckel's cave as well. So if we could get away with it, we'd even want to track it almost up to the brainstem. And of course, our dose is limited. We can't give 60 gray to the entire length of the trigeminal nerve, especially up by the cavernous sinus in Meckel's cave, because the chiasm is right there and it can only really tolerate 58 to 60 gray. So we kind of do what we can, and oftentimes it works. But this is a guy where if we thought he was a decent candidate for reirradiation, we'd walk through the whole process of, hey, here are the risks of reirradiation, severe fibrosis, issues with wound healing, ulceration, non-healing wounds, that sort of thing, hearing loss, depending on, how deep they went before with their fields. And then, as far as treating, the perineural tumor spread, have to make them aware there's a small chance of things like blindness. But I think the alternative is that this thing's just going to keep growing retrograde. And, the other option too is something that I don't do, but, cemiplimab. He might be a good candidate for that if we recognize that he's not a good reirradiation candidate, or he may say, I don't want radiation, thanks.
So question if with the path, so I don't know if you cover this on the imaging, but was the cheek lesion invading V2 and then going back, or was it a V3 way through the parotid? Because technically you could get the auriculotemporal, so I don't know if that changes.
Yeah. Well, for me, this was one of those things where ultimately I kind of said, that's a mystery. It did not jive that the cheek lesion it really wasn't close to the, sort of the main infraorbital nerve. Also didn't exhibit perineural invasion. So that seemed less likely. It almost seems like something happened in the facial nerve and then kind of burned out, or regressed, or is just sort of non-active tumor, so it's not enhancing. The thought was that the best target we can pick from a radiation standpoint to help this guy is the V2 target over the facial nerve, just because it's not clearly positive. That ship has sailed from a functional standpoint. And what really threatens his life is the V2 progression. And it potentially in fairly short order. These people, they don't have a lot else going on, and all of a sudden they've got brainstem squamous cell carcinoma, which is obviously a problem. So that's kind of how we reasoned it out. But whether that's the true reality, I don't know. I was going to make you our medical oncologist. Congratulations. And so unless we have a medical oncologist somewhere out there who can chime in, but knowing what you know about immunotherapy, any thoughts on that?
This would be an indication.
Let's see how he does as a medical oncologist.
For a nice referral to a medical oncologist. and the only other thing I can add just from our tumor board discussions is we talk about something called the CPS score. So the new checkpoint inhibitors target the PD-L1 inhibitors. That's really the basis for most immunotherapy that we deal with. And so technically on the pathology, we do this for like mucosal squam, but you could do it for cutaneous squam and get a PD-L1 marker. Basically, the CPS score tells you how responsive to immunotherapy can be, so you can kind of risk stratify folks. But that doesn't usually preclude people from getting it, but you could analyze that tumor from that standpoint and then consider either I guess you could probably give Panrl for this, or Symposium is.
Yeah, so I think we went through most of this. I mean, I think the thinking for this patient was that we could consider systemic therapy, which would likely be immunotherapy for an 88-year-old. A couple of points I would add in is that we have treated very elderly folks with immunotherapy with pretty good tolerance. So just being 88, unlike say cisplatin or any of the platinum containing agents, or really any of the cytotoxics, this may be an option. And so it was an opportunity to note that both cemiplimab and pembrolizumab are approved for cutaneous squamous cell carcinoma. There are some conditions. They're not considered frontline therapies unless a patient is otherwise untreatable from both a radiation and a surgical standpoint. But they are options. They have in the sort of 30 to 40% response rate. And so the thinking here was, well, let's see how he does with radiation. Potentially trying to do these two together is not going to be well tolerated. If after radiation there's progressive tumor that we can evaluate on imaging, then we still have immunotherapy as a potential option, unfortunately with the caveat of that little bit low response rate. But you're getting, we're sort of running out of treatment options at that point. So that was the thinking.
If I could chime in too, I didn't mention this in my talk, but radiation, we don't fully understand this yet, the total set of mechanisms. So radiation potentiates the immune system against tumors. It's thought to be partially related to the degree of antigen release from tumor death, but there are other components. The radiation itself actually affects T cells in a certain way, but if this patient or any patient is going to be getting immunotherapy down the road, we know, not necessarily for skin cancer, but other cancers, lung cancer in particular, patients who get radiation and then immunotherapy, their response to immunotherapy is dramatically improved in many cases. So getting radiation is potentially going to give this patient a better outcome, even if they don't have a complete response, because the immunotherapy may work better.
Great point. Thanks. Dr. Robbins, did you have a comment or question?
Yeah, I just have to challenge my ability to read an MRI. What would the average patient look like, this MRI of his facial nerve, say 18 months post-onset? Would it be atrophic?
So, if the cause is tumor invasion of the nerve, we'd expect the nerve to be larger, so to be thickened, and generally the nerve is quite enhancing. So that was the mystery here. The nerve is bigger, but it isn't particularly enhancing, which is a little bit unusual if there's tumor involvement.
Yeah, I can appreciate that. It's just kind of a curiosity question, because we wouldn't, I don't think, get a CT, I mean, a MRI scan for somebody who had Bell's and made a poor or incomplete recovery. I don't think, but.
Well, I certainly would have in this patient. As a matter of fact, I never would have diagnosed him with Bell's palsy at all. I would, with these facial nerve symptoms in the air, in the face of a local tumor that had perineural invasion.
I
the
agree.
First place I would have gone is to the imaging, and we may have seen that enhancement at that time, which might have told us at the time, suggested at the time that this was tumor. Rather than the diagnosis of exclusion, which is the Bell's palsy. No, go ahead.
Yeah, can I add one thing there? And I would say, clinically, this patient didn't have complete facial paralysis. He actually had a little bit of lower lip motion still, so it was more of a regional paralysis, which obviously doesn't quite fit the Bell's palsy pattern. And then the lack of any recovery, to me, actually is an indication to image. If someone wasn't imaged up front and you think, maybe this, removing the skin cancer history in this patient, if he presents 6 months out from an acute onset paralysis and no recovery, that's a person that I would get an MRI scan on, looking at the kind of the skull base and the parotid, because you should start to see some recovery in the first 6 months. So if you see consistent enhancement at that stage, or you can pick up a skull base tumor that's causing it, or a facial nerve schwannoma or something like that. So I think failure to recover at all with the suspected Bell's would be an indication for an MRI in a delayed fashion.
Makes good sense. Thanks.
Thanks, Emma. Yeah, I would point out too that a patient with skin that looks like this, even if he didn't have that prior trago lesion, somebody who's had 10 excisions from their, various places on their head and neck, you always wonder, is this something that's cancer related from, just from one of those prior resections? That, I think, is the end for this case. I do have a melanoma case, but I assume you probably want to end at this point. Guidance on that? Okay, that's the end. Thank you very much, panelists, for your participation and great expertise and input. Appreciate it.